I mean, I went to college in the 60s. You know, that's what prompted me to pursue this line of research, because I saw that, you know, I went to an Ivy League school and I went to Stanford School of Medicine, and, you know, I used cannabis, and I don't think it destroyed my life. I'm Donald Abrams, and I'm Chief of Hematology Oncology at San Francisco General Hospital. I'm a professor of medicine at the University of California, San Francisco. In the clinic here at San Francisco General Hospital, we had a volunteer, Mary Rathbun, who was our Volunteer of the Year for 2 years in a row. She was an older woman, and she used to bring her kids, as she called our patients, marijuana brownies. This was at a time when we didn't have any effective therapies for HIV/AIDS, and many people were dying of the so-called wasting syndrome. I was in Amsterdam, of all places, at the International AIDS Conference, and glancing at CNN headline news, and I saw that Mary was being arrested in Sonoma for baking brownies for our patients. And when I arrived home, there was a letter directed to the director of research in the AIDS program at San Francisco General, suggesting that a clinical trial showing the benefits of medical marijuana should come from Brownie Mary's institution, as if she were our dean. But, you know, I picked up the gauntlet and decided, well, that's a good idea. I had found out that the federal government, the only legal source of cannabis for clinical trials, being the National Institute on Drug Abuse, was not interested or has a mandate from Congress that they cannot supply cannabis to study as a treatment. Because, as Dr. Leshner told me when I met with him in 1996, he said, we are the National Institute on Drug Abuse, not for drug abuse. So they have a congressional mandate only to study substances of abuse as substances of abuse, and hence could not give me marijuana to study to see if it reversed the AIDS wasting syndrome. In California, we were fortunate at the end of the last century to have a budget surplus. And with that, Senator John Vasconcellos established a Center for Medicinal Cannabis Research at the University of California through appropriating $3 million a year for 3 years. And that center was really developed to study cannabis as a medicine for the indications that the people of California had voted on in 1996. The federal government, again, deciding that they're the only legal source of cannabis, sort of made arrangements so that they would supply the marijuana for these research protocols, even though they were looking at marijuana's effectiveness, as long as they didn't have to pay to do the studies. So the state of California, the University of California Center for Medicinal Cannabis Research, would fund the research, and NIDA would supply the marijuana. And so that was a big change. The potency of the cannabis that we get from NIDA, the National Institute on Drug Abuse, is low. Averages about 3.5, maybe to 4%. And street cannabis, or cannabis that's from the dispensaries, I think is 8 to 12 to 20%. So that's lower potency. I asked NIDA, can't you make more potent cannabis? You know, and they said, well, it turns out that it's too sticky and it gums up their machine, because they automatically roll their marijuana for research into cigarettes using Pall Mall cigarette paper. So they did actually, for our vaporizer study, they came up with a 6.8% THC, which they managed. I don't know if they hand rolled it or what, but they did manage to make a more potent strain. A number of the studies that we did were on painful peripheral neuropathy, because it's such a hard syndrome to treat and there aren't really effective therapies. Opioids don't really work. Acupuncture is plus minus. Most people use anti-seizure medicines. And I think all the studies from the University of California Center for Medicinal Cannabis Research have shown that cannabis is very useful for peripheral neuropathy. We took patients with chronic pain who were taking an opioid, either morphine extended release or oxycodone extended release, and we exposed them to vaporized cannabis for 5 days. And we looked at the impact on the level of the opioid, the morphine or the oxycodone, in their bloodstream, and the impact on their pain. And we're in the process of writing that one up, but it was very interesting, and it supports what we thought was going to happen, in that the blood levels of the opioid, either the morphine or the oxycodone, were actually decreased, but pain relief was increased with the cannabis. So, that's a very interesting finding. Other studies have been conducted in patients with multiple sclerosis. Again, many patients with multiple sclerosis report decrease in spasticity, decrease in pain, increased mobility, increased mood, improved mood when participating in these studies. We've done a lot of research over the past 20 years when we haven't been able to do research with the actual cannabis on how cannabinoids cause their effects. And what investigators found in the 1970s and 80s was that we have receptors in our body, CB1 and CB2, that complex with these cannabinoids from the plant. Now, why would we, and all other animal species, mind you, have these CB1 receptors? It's not because we're meant to smoke marijuana. What we find out is that we have our own circulating cannabinoid chemicals in our body that don't come from the plant. They're generally produced on demand, and they complex with the receptor, and they cause biological action. So I drink green tea for its health benefit, and green tea has a number of different chemicals that produce these benefits. Similarly, cannabis, the plant, has a number of active compounds called cannabinoids, and they belong to a family of 21 carbon chemicals that all have biologic activity. We believe that there are about 70 or 80 different cannabinoids in marijuana. The most well-known and the most psychoactive cannabinoid is delta-9 THC, and that has been extracted from the plant and put in a sesame oil capsule and has been available as a drug, dronabinol, now for many years. However, there are other cannabinoids in the plant that have activity. A study in Israel looked at delta-8 THC and found that it was equally effective as an anti-nausea drug for children with cancer getting chemotherapy. I think most of the interest now is on another cannabinoid called cannabidiol, otherwise known as CBD. This cannabinoid seems to have really potent anti-inflammatory and anti-pain activity without having a psychological effect or without producing a high. It's a very exciting field, and many drug companies are working to increase production of endocannabinoids or decrease production or block the cannabinoid receptor. Now, there was an example of a drug that was approved to decrease appetite. It was approved in Europe, and it was a CB1 receptor blocker, so that the receptor could no longer bind with the body's own endocannabinoids. And what they found was that by blocking that CB1 receptor, that patients lost weight, but they got depressed and they committed suicide. And that was a bad side effect. So the drug was never approved here in the US, and it's now been taken off the market in Europe. As an oncologist, there's hardly a cancer.
Right, this is a large crowd. Can everybody hear me? No. You stole my microphone? Right. Hi, my name is Kelsey Carpenter. I have epilepsy and I'm battery powered, VNS. Our next speaker is Dr. John McBurney. Dr. John McBurney is board certified in neurology, clinical neurophysiology, and sleep medication. Dr. McBurney specializes in caring for people with epilepsy and general neurological conditions, and heads up the Oregon Clinic Epilepsy Program, and will serve as the medical director of neurological services at Legacy Good Samaritan Hospital, focusing on EEG and long-term monitoring and oversight. This is the VNS. I will demonstrate right now. Sorry. and oversight the Epilepsy Monitoring Unit. Dr. McBurney is passionate about the role that lifestyle medicine, including proper nutrition, stress reduction, and exercise, plays in disease prevention and the delivery of true wellness. Changing voice. That is a demonstration. Thank you very much.
Thank you very much. Can you hear me okay? So that was Don Abrams, who is someone who has really had a major impact on my attitudes as a physician regarding cannabis. I, in January 2014, completed the Integrative Medicine Fellowship founded by Dr. Andrew Weil at the University of Arizona. And Don is one of the early graduates of the fellowship and comes back every January for residential weeks and essentially gives that talk. And I'll have to admit that up until he opened my eyes, I was, like most physicians, dismissive about the potential role of cannabis as a medication. And in all honesty, that attitude was founded really more on misinformation, experiences growing up in the 70s of my own, and I just didn't see what that could possibly have to do with anything. My opinion now, and I really want to thank you all for coming, and thanks to Epilepsy Foundation Northwest for spurring me to put this talk together, because it has been a further amplification of my own interest in this area. And I think that while work in the field of epilepsy is in its very earliest stages, that there is tremendous potential for cannabis to benefit patients with epilepsy and really with a range of human afflictions as we go forward. I'm going to, if I can, take a few minutes to sort of review the history of cannabis, because it's a context that I found to be very helpful. Cannabis is a plant genus with two main species, are Cannabis sativa and Cannabis indica. There's recently been a reclassification of sativa and indica based on DNA analysis, and now sativa is considered to basically be hemp. Indica is more medicinal cannabis with the cannabinoids that we'll be talking about later in the talk. The earliest records of cannabis use dates from about 10,000 years ago in cave drawings in Japan. We know that probably cannabis originated from Central Asia and migrated to Japan by trade routes. But the initial interest in cannabis is really more as a source of fiber, both for paper and rope, as well as for food, because cannabis seeds are a very good source of both high-quality protein and beneficial essential fatty acids. Cannabis has a very long history of use in botanical medicine. In Asia, it's one of the most highly prized herbs in traditional Chinese medicine, and in India, in traditional Indian medicine, or Ayurveda. The picture there is of a mummy from about 2,700 years ago from the central highlands of China. This man was probably a priest or a shaman of some sort, and he was entombed with a number of bags of female flowers of cannabis, and obviously in an effort to protect him and promote his well-being in the afterlife. And there are a number of, there's a strong archaeological record for cannabis being entombed with mummies. Cannabis spread out of its botanical origins in Central Asia into Japan, Southeast Asia, and India around 2,000 years ago, and then spread into Arabia, across northern Africa, into Central Europe. So in those societies, there's really a long tradition of A, herbal medicine, and B, cannabis having a role in herbal medicine. But what really hit me when I looked at this was how recent cannabis in North America is, only in the 20th century. So in terms of our societies being able to understand, incorporate this, I think we're really kind of in our infancy at best compared to its role in other societies. There was an Irish, McBurney, Irish physician, William O'Shaughnessy, who did most of his life's work in India, discovered cannabis as a medical treatment, also discovered intravenous therapies, and also in his spare time developed and ran the Indian railroad system, for which he was knighted by Queen Victoria. And he actively promoted the use of cannabis extracts in his own practice in India and popularized those back in Great Britain, in the United Kingdom, and the result of which is by the beginning of the 20th century, essentially all the major drug houses featured over-the-counter patent medicines containing cannabis extracts. The advertisement you see here is from Park Davis, who around the turn of the century, around the same time that they were working with Tracy Putnam and Houston Merritt in developing phenytoin, which they later marketed as Dilantin, was also actively marketing cannabis-based medications for a variety of ailments. And can't really read this. The copy didn't come out that clearly, but essentially it says that Park Davis American cannabis is just as good as Indian cannabis, only cheaper. I think it's been a long time since we could say that about anything from this country that was pharmacological. So cannabis extracts were marketed for a wide variety of symptoms, undoubtedly reflecting the pleiotropic or multiple effects of the endocannabinoid system, including nervousness, insomnia, loss of appetite, melancholy, which we would call today depression, and seizures. There was really no history in this country at that time of any medicinal use of cannabis through combustion, smoking, or vaporization. It was all taken by fluid extracts or by tinctures, which is an extract made with alcohol as opposed to water or glycerin. But the oral administration, the absorption was very erratic and poor, and so over time these medications kind of fell out of favor both with the public and the manufacturers, and then, as we'll see, cannabis prohibition came about. The first step in the cannabis prohibition, which followed repeal of alcohol prohibition but involved some of the same key figures, was the Marijuana Tax Act of 1937. And as you can see, and I've been deliberately not using the term marijuana for cannabis. Cannabis is the genus name for the plant. It is the scientific term. It is the term that is used everywhere in the world except for the United States and Mexico. And they even spelled it in the most inflammatory fashion possible with marijuana with the H, again, to imply that there was something evil, something crossing the border from a foreign place, and to whip up xenophobia on a part of the American public. But anyway, the Tax Act that was passed through Congress imposed a tax for the first time on marijuana of $1 per ounce for medical use and $100 per ounce for non-medical use, which in 2014 terms would be the equivalent of $1,637 per ounce federal tax. And so at that point, cannabis became essentially unavailable. Subsequently, cannabis worldwide got swept up in the movement to eliminate the interstate transport of opium. And so cannabis was lumped in with opium. And through various treaties, access was further restricted, culminating in the United States in 1970 when marijuana and all cannabinoids, and that would include CB1, cannabidiol were placed into Schedule 1 by the DEA. Schedule 1 drugs are those for which have high abuse potential and for which there is no accepted medical use. Other substances or drugs that are in Schedule 1 include PCP, ecstasy, heroin, LSD, and cannabis, all forms of whether psychoactive or not. So as a result, just as with alcohol prohibition, a substantial cannabis underground emerged in this country and around the world, and there was an emergence of a social movement which I've termed cannabis activism. And, you know, cannabis activism is the opposite of the stereotype of the Cheech and Chong movie. People who are cannabis activists, I think really from a very deeply spiritual and philosophical place, believe that this genus of plants, which co-evolved with man and which interact with a very fundamental part of our animal physiology, are there, whether through evolution or creation, however you want to view it, as potentially beneficial to humans. And it's a deeply held belief for which they work tirelessly. And people do tend to vote with their feet. In response to this, the Epilepsy Foundation issued its statement in 2014 regarding medical marijuana, which you find beneath the picture. The Epilepsy Foundation supports the rights of patients and families living with seizures and epilepsy to access physician-directed care, including medical marijuana. In the last year or so, around that same time, there has really been a firestorm of interest in this, in part due to the publication through Sanjay Gupta's documentary Weed and through the internet of the story of Charlotte Figi, a little girl in Boulder, Colorado with a really severe epilepsy of early childhood called Dravet's syndrome. Charlotte was basically dying with up to 300 seizures a day that could not be even touched with conventional pharmacological treatment. In fact, the seizure or the AEDs were really not accomplishing anything. She was off treatment, regressing developmentally. Her father was in the military and was desperately searching from Afghanistan on what could we do to help Charlotte, and stumbled across some growers that were growing high CBD cannabis, and lo and behold, they were in the Boulder area. And to make a long story short, they started Charlotte on high CBD extracts coming from plants that have subsequently been known as, or become known as Charlotte's Web, and her seizures went from 300 a day by parental report to a couple of nocturnal seizures a month, and her development went back on track. I don't care how hard-hearted or cynical or evidence-based you are as a physician, those are the types of signals that you simply have to pay attention to. Sanjay Gupta, who is a faculty member at my alma mater, Emory University, a very fine, traditionally trained neurosurgeon, and as you all know, a medical correspondent for CNN, and previously selected by President Obama to be Surgeon General of the United States, a position that he declined, but certainly no lightweight and no out there kind of fringy person, was, I believe, assigned to do a story on cannabis, and was initially, just like I was before I heard Don Abrams speak for the first time, very, very skeptical. And if any of you haven't seen the CNN special Weed, and then the follow-up to that Weed 2, they're easily accessible in their entirety on the internet. I strongly encourage you to do so. But the bottom line is that Sanjay Gupta went from being skeptical to actually pretty irate that more work wasn't being done to explore the benefits of cannabis for patients with epilepsy and other conditions. And as you can see from the quote, he's gone from being a skeptic to admitting that he was wrong. I just would like to review a little bit because this is really complicated, and honestly, I don't understand all the details, but to paint you some of the broad brushstroke facts as we know them about cannabis pharmacology. So the main active ingredient, but not the only active ingredient, in cannabis are a series of fats called cannabinoids. They're 23-carbon fatty acids derived from essential fatty acids that are the main active ingredients. In the plant itself, they're in acidic form. The main psychoactive form is tetrahydrocannabinol acid, which with heating is converted to neutral THC. That's the main psychoactive component in cannabis, delta-9 THC. There are, as you heard from Dr. Abrams, about 70 cannabinoids, and research suggests that about 10 of those are probably biologically important. The one that has aroused the most interest in the epilepsy community is the CBD, or cannabidiol, which is a non-psychoactive cannabinoid that's found in varying percentages depending on the specific cultivar. It tends to be high in cannabis indica, but through selective breeding and crosses, it can be enhanced. And it's that type of cannabis, high CBD, low THC, that the initial beneficial observations were made. In addition, though, to cannabinoids, there are a number of other compounds, such as terpenes, which, for one thing, are responsible for causing the smell or the aroma of burning cannabis, and which also may play roles in modulating the effect of the cannabinoids. So that's the compound, that's the plant. So what about our brain? Well, there are two main cannabinoid receptors, or endocannabinoid receptors, although I believe now there may be as many as possibly 5 different receptors identified, but the main two are CB1, which is the second most prevalent receptor in the human central nervous system, second only to GABA, GABA being the site of action of benzodiazepine medications that are used for the acute control of seizures. But in contrast to GABA receptors, CB1 receptors are not found in the brainstem, which accounts for a unique pharmacological property of cannabis, which is that it has a very low toxicity profile acutely. And in fact, it is often stated, and I believe it to be true, that there has never been a documented case of death due to overdose of cannabis. And we certainly can't say that about conventional anti-epileptic drugs, nor can we say, and certainly not benzodiazepines. The main peripheral receptor is CB2, which is found on blood monocytes, as well as a number of other cells that are involved in the immune system, and appears to exert a lot of its immunomodulatory effects, anti-inflammatory effects, and potentially anti-neoplastic effects. There are extremely complex interactions between THC and CBD. From the standpoint of people that use cannabis as a recreational substance, THC is said to promote a high, and CBD is said to promote chilling out or being mellow. That's a subjective appreciation. There are undoubtedly pharmacological bases for that. They've not, to my knowledge, been completely worked out. It's not clear in my reading the literature that CBD even binds to the CB1 receptor. So it may modulate activity by endocannabinoids at the CB1 receptor, and especially by THC at the CB1 receptor. That's really important when it comes to the studies that are ongoing, and some of the practical pharmacology. We've alluded to the endocannabinoid system. It's really interesting and important to realize that the endocannabinoid system was only discovered after the isolation and synthesis of delta-9 THC by Meslam in Israel, when he went looking for, well, what in the world does this do in the brain? It's not like we knew all of this neuroscience and then discovered the chemical. And this isn't unique. In neurology, we often find that clinical observations lead to queries that lead to breakthrough insights in understanding how the brain works and how it fails in disease. A great example being the role that dopamine plays in movement. That was not understood to be the basis for Parkinson's disease until clinical observations that giving people L-DOPA resulted in reversal of their Parkinsonism. If any of you have seen the movie, I think it's Awakenings, that really kind of popularized that phenomenon. The endocannabinoid system there are two known main endocannabinoids, anandamide and 2-AG. And it appears, although I think work in this area is extremely early in its infancy, that this system functions with regard to long-term regulation of multiple physiological functions, including appetite, pain, sensation, mood, and also memory. I've already alluded to the low acute toxicity of cannabinoids due to the lack of CB1 receptor in the brainstem. However, there are concerns about chronic effects, especially on developing brain. The main concern is, as stated in the question, does regular use of cannabis increase the risk of developing schizophrenia? Now, Don Abrams says, and I believe Don, that a lot of these epidemiological studies are severely flawed and confounded by the fact that many adolescents who are developing schizophrenia and have severe anxiety may self-medicate with cannabis. So the fact that they go on to demonstrate schizophrenia is not the same as showing that the cannabis caused the schizophrenia. That said, there was a study just published a couple of months ago, I think in the British Journal of Psychiatry, although I may have the journal wrong. There was a case control study looking at the risk of developing psychosis in individuals who used or who regularly used a very highly potent form of cannabis called skunk cannabis that has up to 30% THC compared to those that did not. And they found an increased risk of developing psychosis with habitual use of skunk cannabis. So I think that, you know, I would be surprised if we had a biological system in the brain that you could regularly pummel with an exogenous ligand, that it did not result in some unforeseen consequence. You know, the brain tends to seek equilibrium so that regular anything will result in what's called oppositional tolerance. Anyone who's taken a very potent anti-seizure medicine in the form of a benzodiazepine for a long period of time may have experienced the phenomenon that after a while it becomes less effective, and then when you try to take it away, big problems can ensue with breakthrough increased seizures. So I think that anything can be abused, and certainly there is grounds for caution with regard to long-term safety, especially in the developing brain. Another concern that frequently is brought up, especially for combusted or smoked cannabis, pertains to the issue of lung damage and in particular lung cancer, carcinogenesis. It's an extremely interesting area, and it may be a function of what I already alluded to, which is the immunomodulatory effects of cannabis. There's a large-scale retrospective epidemiological study out of Group Health Cooperative in Seattle that looked at the incidence of lung cancer in their patients based on whether they smoked tobacco, whether they smoked cannabis, whether they smoked cannabis and tobacco, or whether they didn't smoke. And the lowest rates of lung cancer, in fact, with 0 cases of lung cancer, were in the cannabis smokers. So non-smokers had higher rates of lung cancer than cannabis smokers. And tobacco smokers who also smoked cannabis had lower rates of lung cancer than people who just smoked tobacco. I'm not going to tell you that I'm recommending to my patients that they smoke cannabis for an anti-cancer effect, but it is a very interesting observation, and I think, again, it points to the extremely rich biological complexity of these family of compounds. There also are tissue culture observations in glioblastoma tissue culture that simply applying a whole plant cannabis extract to glioblastoma in tissue culture kills the glioblastoma cells. That has not been applied in clinical trials. There's so many things that can happen between the tissue culture and the person that, believe me, I'm not routinely recommending to patients with glioblastoma that treatment with cannabis be an alternative to conventional therapy. Although, in all honesty, if I had glioblastoma, I'm not sure what I would do. But you're not here to learn about lung cancer. You're here to learn about cannabis and seizures. So at a basic science level, cannabis extracts have been screened against essentially all the models of seizures, both focal and generalized, and have been found to be effective in models of generalized and focal seizures affecting both initiation, propagation, and spread. Now, that said, we're dealing with a complex family of these terpene, endocannabinoid, or cannabinoid molecules, and some of these seem to indicate some preparations that THC can increase seizure activity. Pretty consistently, CBD is shown to be anticonvulsant. So at a basic level, in terms of the anti-epileptic drug screening process, there would appear to be some grounds for optimism and interest. There's really a very forward-thinking company in Great Britain, GW Pharmaceuticals, which has one product in the pipeline that I know of, Epidiolex, and another product, Savitex, which is approved in Europe for treating pain and spasticity in MS. It's an oral mucosal cannabis spray. And they have built their entire research platform going forward in multiple areas, including not just epilepsy, but endocrine regulation, inflammation, neuroprotection. And I would encourage you to go to gwpharma.com website and read about their big picture concepts going forward. But they have developed a product called Epidiolex, which is extracted from whole cannabis plants, but then it's isolated CBD. And they've been successful in getting orphan drug designation from the EPA with expanded access and fast track evaluation as a treatment for people with epilepsy that is treatment resistant. And we are starting to get some results. Right now they have approvals for a total of 300 patients under these INDs for treatment in individuals ranging from 1 to 40 years of age, but with 95% designated for pediatric patients. Now, there have been prior clinical trials of cannabidiol in epilepsy. There were 4 prior blinded trials. They involved incredibly small numbers of subjects, both for the control group and for the active treatment group. If they were randomized in a 50-50 fashion, there are 4 studies with about 40 subjects total. And 2 of those studies showed statistically significant improvements in seizures, and 2 did not. But anyone who knows anything about statistics would tell you that those studies, unless you had literally a cure for a condition, and I don't think anyone is saying that cannabidiol is a cure for epilepsy, you would not be able to show it even with all of those data being pooled in such a small number of subjects. They were statistically underpowered. So here we are to the central part of the talk, which is CBD and epilepsy. Porter and Jacobson did a Facebook sponsored, or not sponsored, but they developed a user group on Facebook that people could sign up for if they had epilepsy that was treatment resistant. And they did a survey through Facebook. They had 19 qualifying respondents that were using CBD enhanced cannabis for epilepsy. And of those, 84% indicated that their seizures were controlled, and 42% had an 80% or greater reduction in their seizures, with 11% of that group reporting that they had become seizure-free. The side effects, interestingly, are mostly seem to be positive. The additional effects were known to include better sleep, improved alertness, improved mood, but also some decreased appetite, fatigue, and drowsiness. So that's a very uncontrolled, unselected group of individuals, but it kind of gets a feel for what people are doing and what people with epilepsy are experiencing. So based on the expanded access program and the orphan drug designation, the first report of 23 patients, all treated at New York University, was reported this past December at the American Epilepsy Society meeting, where, by the way, I think that at least 10% of the meeting was devoted to cannabis and epilepsy. There was not only a number of abstracts and platform presentations, there was a half-day investigator workshop and a full-day symposium in the Merritt Putnam Epilepsy Symposium, which is a satellite meeting of the meeting, which is the largest meeting of epilepsy professionals in the world. So that gives you any sense of just how much interest and excitement there is in the epilepsy professional community about this. In any case, the characteristics of the patients that were initially treated in the open label, meaning there's no placebo control, Epidiolex study, 9 of the 23 had Dravet syndrome, 4 had myoclonic absence seizures, 3 had Lennox-Gastaut syndrome, 2 had unspecified general epilepsies. There were some that were characterized by specific receptor genotypes. And overall, 39% of these subjects had a greater than 50% reduction in seizures. So that's generally in studies classified as a responder rate of 39%, which I think is certainly comparable or superior to most clinical trials involving people with conventional AEDs and treatment-resistant epilepsy. There was a 32% average reduction in seizures, and most startling of all is 1/3 of the Dravet patients became seizure-free. The seizure freedom was much less likely to occur in other epilepsy types. Again, while the treatment was generally well tolerated, side effects of somnolence and fatigue, and also, importantly, increases in some anti-epileptic drug levels, in particular clobazam, or Onfi, which is indicated as a treatment in Lennox-Gastaut syndrome, is something to really be aware of. My experience treating a few patients with clobazam is that it's extremely sedating. It's a benzodiazepine that's been available in Europe for 20 or 30 years and fairly recently has been licensed in the United States. It seems to have advantages over other benzodiazepines in causing less tolerance with long-term treatment. But it tends to be used in these severe epilepsies of early childhood. It's very sedating, and so administering either Epidiolex pure CBD or potentially high CBD cannabis could potentially make the patient become toxic with clobazam. That's something to really be mindful of. Also, effects on appetite and GI motility were also noted. Some patients had increased appetite, others decreased in weight loss. So this past Monday, on April 13th, an advanced release of the extension of this open-label trial was released on the American Academy of Neurology website. This is an abstract which will be presented at the upcoming American Academy of Neurology meeting in a couple of weeks. And this is, again, out of the same, headquartered out of the same group with Orrin Devinsky, who's the head of the epilepsy program at NYU, as the first author. But this is an extension of this expanded access program at 10 centers throughout the country involving 213 patients. To qualify for analysis as to effectiveness, the individuals had to be on treatment for at least 12 weeks continuously, and 123 of the 213 were available for that. Since this hasn't been presented, I really don't know what is the deal with the other nearly 100 patients, but I suspect they just haven't been in the study long enough to qualify for the 12-week criteria. This is very fast-moving. These individuals had treatment-resistant epilepsy of many etiologies. The things that stood out were a 42% overall reduction in seizure frequency in treatment-related epilepsy overall. In Dravet syndrome, a 51% reduction of seizures, and in Lennox-Gastaut syndrome, a 52% reduction in atonic seizures. Now, it's really important to remember that these are uncontrolled and unblinded studies. One of the things that I've been told by physicians who've been in states where this, Charlotte's Web has been available for a while. I have a good friend in Aurora who's a child neurologist, been there for about 20 years. And of course, Charlotte's Web has recently been able to be exported to California, but pretty much because of federal law, the only place you could get it up until very recently was in Colorado, and because you could potentially be arrested if you tried to personally transport it out, it basically meant that families were having to move to Colorado to be treated with high CBD cannabis, quote, Charlotte's Web variety. Was that the single biggest factor that predicted a positive response to Charlotte's Web was the number of miles that the family had to move to get access to it. Belief is a very, very powerful thing, and it can affect all of our perceptions. And I think that, I hope that the trials that are being organized now will be done so in a very fair and methodologically sound way to give us either final confirmation or at least further characterization of the a role that manipulations of the endocannabinoid system may play in treating epilepsy. The biggest single problem, and if I could have you take away anything from this, it's the need for you all to be informed, and if you're so inclined to reach out to your government officials, your congressmen and senators, is the continuing listing of cannabis, including non-psychoactive forms of cannabis such as CBD, in Schedule 1 by the DEA. I can't really write a prescription or officially recommend cannabis to a patient except as a potential herbal self-help remedy without fear that I would be doing so in violation of my DEA certificate, which allows me to practice without restriction and to prescribe all the drugs, including Schedule II drugs like oxycodone or morphine. So there really needs to be a change in the law. And right now, Senator Booker has sponsored legislation. He's the junior senator from New Jersey that has been co-sponsored by the junior senator from New York, Kirsten Gillibrand, and, believe it or not, Rand Paul from Kentucky, who is a physician, to take cannabis out of Schedule 1. And I think, I'm hopeful that will occur, but given the way things work in our legislative process now, I don't know how optimistic I can be. We really need more research. When I did a Google search for marijuana plus epilepsy, I got 692,000 hits, but when I did a PubMed search for randomized clinical trials with the same search terms, I only got 2 results. So the result is that there's a lot more folk wisdom, I think, and a lot more determination to do things than there really is medical basis to either say it's good or bad. You know, I wind up spending a lot of time saying, I just don't know, and I don't have any basis upon which to make specific recommendations. I would say that once this is done, that there are a number of research challenges for the future. One of the things I've taken away from my training in integrated medicine is that we need other research methodologies other than the double-blind, placebo-controlled, randomized clinical trial to look at the effects of complex interventions. You know, an example of this is there are now a series of studies that have been published in extremely high-profile journals like the New England Journal of Medicine looking at the Mediterranean diet, which isn't like one thing. It isn't a silver bullet. It isn't, you know, take fish oil or take vitamin C. It's a whole range of interventions in diet and the effects on the risk of heart attack, death due to any cardiovascular cause, stroke, type 2 diabetes, and Alzheimer's disease are much greater than any single intervention, pharmacological intervention that I can recommend. So that's an example of how complexity in an intervention can be shown to result in a complex beneficial outcome. And I think we've got to think of manipulations of the endocannabinoid system at a similar level of complexity. I also would like to acknowledge that I think that there's a lot of knowledge derived from practical experience at the level of high-quality marijuana dispensaries, and that we in the medical community need to establish bridges to that community that allow us to work together. We know a lot about epilepsy. We're not botanists, and we don't know a lot of practical things about different cannabis strains and how they are biologically active. But I think, in a way, this genus of plants is like a gold mine of potential chemicals that either alone or in combination can be beneficial. And if we simply focus on 1 or 2 marker molecules, we're going to miss the boat. And I hope that we could develop a truly integrative model in which cannabis, as an example of an evidence-based complementary practice, could be used in a constructive way with conventional pharmaceutical treatments and surgical treatment options. For additional resources, I would very strongly recommend Sanjay Gupta's documentaries Weed and Weed 2. Also, the video that was playing as some of you came in by Dr. Donald Abrams on the science of medical marijuana is very, very informative. A great book that the father of one of my patients told me about that I found to be invaluable in preparing this talk is by Michael Backus, Cannabis Pharmacology, Practical Guide to Medical Marijuana. Just came out in November. It's extremely well written. It's extremely scholarly, well referenced. And then there is just a ton of information on the GW Pharma Pharmaceuticals website, gwpharma.com. So I thank you very much for your attention. I'm going to stick around for the panel discussion at 2:30. So if anybody has a burning question or comment now, we'd certainly be willing to field that. But if not, there'll be time at the panel discussion to ask questions as well. Yes? I think CBD's available now under the OMMP. My only question is, can I be certain of a given supply of CBD-enriched cannabis, the raw herb, or extracted in oil to be what it says it is? You know, what are the quality parameters? And, you know, it's really, you know, that bridge building between the conventional medical and the dispensary is far from taking place. I have not knocked on the door of marijuana dispensary to introduce myself and say, can you teach me about what you're selling? My understanding, though, is that, you know, I'm not going to get very far if I do that. So I don't know that changing it to be available recreational changes very much, except that OMMP, the Oregon Medical Marijuana Program, there is an application process, and you have to have a physician who's willing to sign your application, and it costs a couple of $100s to complete for the individual to do that. The biggest other thing that I see is the cost associated with some of the CBD enriched products. It can approach the cost of conventional pharmaceuticals without insurance. Yes? It's oral. I don't know. I think it's in oil, and it's a gelatin capsule with oil. All these, all the cannabinoids are essentially lipids. Yes. Yeah. Yeah. Yeah, I think that the starting place for any heroic, compassionate type of treatment is in individuals for whom no other help is available. I get really, really uncomfortable when I have patients that I know have very non-treatment resistant epilepsy syndromes who say, I'm not going to take medications, I want you to fill out my medical marijuana application, because I don't know if it works for them. I think that it's worth keeping aware of. Kind of the progress is really starting to take place rapidly. I was hoping to try to get Epidiolex in Portland, and I understand it's possible that OHSU and child neurology may be a site. I haven't been able to confirm that. But if you watch Weed 2, what you see is that because cannabinoids, even non-psychoactive cannabinoids like CBD, are classified as Schedule I drugs, that NYU, which is, you know, a massive research university, that it nearly exhausted their institutional resources to get through all the levels of federal regulation. And it especially hit home when Orrin Devinsky, who I know, takes Sanjay Gupta into the med room and shows him the 3,000-pound safe that they have to keep Epidiolex in, even though it has no abuse potential, because that's what the federal regulating authorities said. So I sort of gave up at that point. But I think that I mean, they are rapidly organizing the randomized clinical phase 3 trials, and I bet we'll know pretty quick because, I mean, there are a lot of people would be interested in being in those trials, even if there is a 50-50 chance of being in a placebo group. I don't think they'll have trouble recruiting. Okay, well, thank you very much.